Okay, let's start the part 2 of the preliminary examination, which is assessment of the tear film. It's very important, yes. So preocular tear film plays an important role in contact lens wear. It's always important. So maintain hydration in soft contact lens, determines wearability, act as a primary anti-refracting surface, no matter what, with or without contact lenses. Always tear lens is a primary anti-refracting surface, and much of the deposits, whether it's protein, lipid, mucins, on the lens surface is due to the tear film. Yes, it's due to the quality of the tear film. So poor tear film quality or quantity reduces the patient prognosis of successful contact lens wear. It means if tear film quality is extremely poor, the success of contact lens is extremely chances of success of contact lens is extremely low. So chances of complications are high. Yes. So assessment techniques are basically invasive techniques and non-invasive techniques. In invasive techniques, we think about invasive T-word, uh, definitely flourish, Somus test on phenolrethed test and all these things. And non-invasive techniques, so it basically not stimulate any irritations on the conjunctiva and do not stimulate reflex tearing. Yes, and their effect accounts for the final assessment. So, what do we generally think about invasive techniques? We think about tear backup time. Basically, invasive tear backup time. We put fluorescein and then we measure tear backup time. It's normally invasive tear backup time. Summers test, Summers one or Summers two, no matter what. Phenol red thread test and Rose Bengal stainings. So, tear backup time in general, I'm not going to deal extremely deep, but in general what we do is we put fluorescent and we see if there is a dry spot. Yes, so I think you have to read all these things by pausing video, and while average reading is generally we consider 15 seconds or higher or greater than 10 seconds, we consider normal, and it's if it is less than 10 seconds we think it suggests that tear film is abnormal. Someone says, yes, it's basically tear volume test. Yes, it's not about tear quality test, it's about tear volume test. And it's a test about aqueous humor. Yes, so it's a filter, and we put into the eye and we see in 5 minutes how much that filter test is become wet. Yes, that's all it is. So it's in general normal less than 5 mm is definitely very dry, severe dry. 5 to 15 mm is moderate dry, and greater than 15 mm it's normal. Roughly in summers first, yes, summers second means basically means anesthesia. Basically, we remove the irritation. Basically, we remove the reflex tearing. That's it. Yes. So other thing is normal. Just the normal reading is approximately 10 mm for 5 minutes. Yes, some second. So phenol red thread test is another test for basal tear volume. It incorporates a pH sensitive indicators, that's phenol red, and when it touches to the tear and it changes the color. Basically, it's 70 length. Phenol red thread is especially two polycotton thread is inserted into the lower temporal cul-de-sacs for 15 seconds, and eye closure is immediately after the insertion. So it's quick test basically. So basically phenol red changes color to yellow, and we will see in 30 seconds what happens. On average weighting of 16.7 mm 57 is considered normal. If it weighs less than 6 mm, indicating potential dry. That's it. So rose bengal test is just simple staining test. Yes, dye is presented inadequate tear suction is adversely affected by epithelial cells or decrease in protection from rose bengals, and that's why rose bengal take stain. So despite of early belief, rose bengal is only absorb both dead cell and mucus cell. Recent studies shown that it is stains surface epithelium either poorly protected or unprotected. So basically, it stains either poorly protected or unprotected um, surface epithelial cells. So cytotoxicity is another features of rose bengal. So exposure to rose bengal leads to morphological change and loss of cells motility and cells detachment and ultimately cells death. So that's why we call rose bengal cytotoxic propensity. And photodynamic property has also been initiated, where the phototoxic efficacy followed by exposure to light. So another feature of rose bengal is photodynamic property. So what are the non-invasive techniques? So non-invasive techniques, one important technique in non-invasive tear breakup time, where we do not put fluorescein, or we measure tear prism height, or we evaluate lipid layer. Yes. So what is non-invasive tear breakup time? It can be assessed by slit lamp or tearoscope. What is the disadvantage? It's basically with slit lamp, heat generated by slit lamp causes the evaporation of the tear film, which may affect NIBUT and give that reading value less than what is actually there. So tearoscope developed and described by Gulileon 1993 used the cold light sources which allowed the true estimation, then slit lamp. That's the tearoscope. So one term which is fascinating term, many of the students don't know about this term, is TTT, tear thinning time. What is tear thinning time? It's basically variant of NIBUT, non-invasive tear break time. It's done by keratometry. Keratometry is used instead of slit lamp or tearoscope, while the blink is held whenever the blink is held, definitely whenever we want to know the breakup time, then we definitely held the blink. Keratometric Myers images are observed and the time the first disturbance is noted. You normally notice this thing, and you do not perform this TTT regularly in clinic, but whenever you want to do, it's very easy, and just do it 1 or 2 times. You will then become pro in this TTT. But it's very fascinating. Very first time you noted the disturbance of the tear film, Meyer of the keratometry, that's TTT. So any image disturbance attributed by alternation of the tear film, shorter time than NIBUT definitely have been reported, suggesting a greater sensitivity in tear film changes. But I love this TTT. So it's very useful whenever you have keratometry and just do that Meyer disturbance thing. It will be helpful to understand what is TTT. So lipid layer evaluation, it's very important nowadays. So thicker lipid layer are better for the prevention of evaporation, isn't it? That's why lipid is there. It basically prevent evaporation of the aqueous. It's so greater the tear film stability. Basically, greater the lipid layer thickness, greater the tear film stability. So using either tearoscope or diffuse slit lamp or high magnification of tear film lipid layer can be examined and estimated the tear film stability. So tearoscope is focused on the preocular tear film, and the patient is asked to blink once. The time taken for discontinuity of tear film appears to measure with a stopwatch. It's very important. You have to measure the time. Yes. So contact lens alter the stability of, definitely it alters the stability of tear pre-lens tear film, and it is thinner than definitely what is normally preocular tear film. So another test is easy with the slit lamp is associated with the lower lid margin tear reservoir, from which upper lid spreads the tear. Normal tear prism height is analog to the tear reservoir volume. Basically, it's just the concept, yes, and can be measured using the eyepiece graticules. And it's normally what we think is 0.1 to 0.3 mm is normal height of the tear prism height, and if it is less than 0.1, we think it's dry eye. So other method to measure the tear prism height have been proposed and measured with vary from. So that's data from one author to another author, but in generally we think this value is a correct value. Yes, 0.1 to 0.3 mm. This is central important, that spectacular refraction. But we have to refract with a normal approximate vortex distance, and then we correct it if there is a spectacle power is greater than 4 or plus 4 or minus 4. But definitely you must understand, whenever we do vortex correction for astigmatism, we will correct vortex power according to different meridian. We correct for vertical and horizontally separately. Not, we are not going to do the vortex distance correction with the spherical equivalent. That's the wrong concept. Okay, we always do with each meridian. So accommodation and convergence, which is very important point, because we have already discussed in the optics of contact lens that whenever myopic spectacle wearer shift from uh, myopic spectacle to contact lens, then he needs more accommodation and he has to do more convergence. At the same time, that's exactly opposite for hyperopia. That's why it's very important that you think about accommodation and convergence, especially patients with a high refractive error, especially no matter what, hyperopia or myopia, but you have to think about it. Okay, just pause the video and read all these things. So binocular coordination, another important point. I have already told you why it happens, because with spectacle with minus power, there is a Bayesian effect. With a spectacle with plus power, there is a base out effect. So both the Bayesian and base out helps in convergence, or exert the patient should exert more convergence. It's dependent on the refractive error, but definitely there is binocular coordination changes when we shift from spectacle to contact lens. That's why we have to understand these small things, but it's very important. Yes, the spectacle gave base in or base out effect. With contact lens, do not give any base in base out effect, because contact lens moves with the eye. It always moves with the eye, so there is no base in or base out effect. Whether if there is something, then it's like negligible something. Yes. So what are the special consideration that we have to discuss? It's like, generally, if there is extreme refractive error, the health of the patients, ocular conditions, especially medications, previous RX, what are the occupations and environments, we have to give special consideration if there is anything. For example, if there is high myopia, so we must think about compensating uh, vortex distance, especially greater than plus or minus 4. Then we have to do meridian difference, meridianally, that vortex distance, because it's basically effective power. So ideally, trial lens back vortex power should be close its final power possible. Yes, it should be close. Ensure the high power trial lens should has suitable suitability thin edge. So it's very important that we have to know this all these things. Yes, and consideration more important with the rigid lenses. So if there is progressive myopia, then what we have to understand, the progressive myopia may require potentially expensive, relatively frequent alternation of RX. That's very important. That's why we have to understand disposable contact lens program may be economic, because we know we have to change the contact lens. Yes. So progressive myopia requires more frequent consultation to monitor refractive changes and contact lens aftercare. So we don't rush into prescribing, like for example, for 1 year. Yes, we have to keep them in close monitor of follow-ups. So high astigmatism, it's central important. High astigmatism, we have to think about a lot of things like stability of contact lens, whether we will prescribe uh, RGB contact lens, or sometimes it's, if too high astigmatism, we think about even scleral lens. Yeah. So it's very important that extended period more tolerant to a small degree of residence. So if there is high astigmatism, they are more tolerant to a small degree of astigmatism, but we have to think about astigmatism in different scenario. So keratoconus, definitely in keratoconus, for example, rigid contact lens is most for their even the day-to-day activity, and even uh, they are very very helpful for the quality of life. Yes. So spectacle refraction is difficult. Auto refraction may provide satisfactory starting point, but I think it's not the case. Auto refractor also gave wrong value, but yes, you have to incorporate uh, topographic uh, value of astigmatism in conjunction with subjective refraction and objective refraction. It's very important. So it's prudent to ascertain the type and degree of keratoconus. We must know these things, and even for the keratoconus, we have to know high order aberration and all these things. We should know these things, and higher aberration before and higher aberration after scleral lens trial, which is another important aspect. So hyperopia, we have to know, because hyperopia contact lens is central thick. That's why their digivity is lower. We have to think about these things. Yes, especially hyperopia. So more hypoxic condition at the center of the cornea can be happen in case of high hyperopia, especially like aphakia. Yeah. Then at the particular time we think about what do you call that? special lens, the phakic lenticular lens. Anisometropia, which is another important point, and I think one of the best way to manage anisometropia is through contact lens. But at the same time, contact lens having two different, very different power will create a patient a different sensation. Because, for example, if two eyes are different minus power, then having larger minus power will definitely have uh, thicker edge, and that thicker edge interact with the eye differently. Yes, so it's very important that we think about it and we do all the calculations what is correction. So we have to think uh, what are the different parameters between the two eyes if there is anisometropy. So it's always better. Contact lens always eliminate prismatic imbalance with a spectacle. Contact lens are always best option as we have in anisometropia, but we have to be cautious that there is a huge difference between two eyes. Basically, huge difference, like for example, axial length, whether corneal curvature, or definitely there's a difference between power between two eyes. So the contact lens are different, contact lens thickness are different, contact lens dk by t is different. That's all the things we have to consider. So monocular diplopia, yes, obviously, if there is a monocular diplopia, then we have to think about pupil. We have to think about corneal uh, opacities. We have to think about whatever called the high order aberrations. All these things must be considered, taken into account. Yes, high order aberration can create in keratoconus, can give diplopia and polyplopia. Yes, sometimes. So general health is also important. We have to take care whether the patient is diabetic or not, whether the patient has allergy, whether the patient has arthritis, whether the patient is pregnant or sinus problem. These all things should be considered before fitting contact lens. Yes, fitting contact lens, especially with general disability systemic disease, should be approached with a caution and careful consideration, given likely to affect the contact lens wear. It's always likely to affect the contact lens wear. So therapeutic lens may be fitted to alleviate symptoms accompanied by some conditions. For example, basically one of the example of therapeutic illness is systemic condition which leads to severe dry eye. For example, Stevens-Johnson syndrome, and there are a lot of things. Yes, but if patient is diabetic, then we have to know sensation of cornea is decreased in case of diabetes. So uh, it's high chance that we insert the contact lens and contact lens create a lot of problem. So that's why we have to know if the systemic condition is there patients. Yes, allergic at the same time, that's same thing. That's why patient with allergic can be fitted with contact lens but require more frequent aftercare, and sometimes we have to be cautious if contact lens solution creates some problem or not. So we have to monitor frequently. Arthritis, many of the arthritis, even treatment of the arthritis will give acute uveitis. At the same time, arthritis and their medications are correlated with the dry eye. That's why we have to know if the patient is having any arthritic problem or not. So according to them, we have to, even we can prescribe a tear substitute along with the contact lens. Yes, it's very important. So that's why in case of rheumatoid arthritis and many other disease, arthritic disease, so keratoconjunctivitis, keratitis, and scleritis is correlated. It's very important. We have to take that history into account. Yes, lubricating are often necessary, as I have already told you. So pregnancy, what happens? Why pregnancy is important? Because pregnancy brings hormonal disbalance. Yes, systemic changes that can affect the metabolic process of cornea. Even there is a rapid change in tear volume and dryness, and cornea swelled sometimes. Yes, it's very uh, fluctuating situation. Pregnancy means so the retention of water swell in the cornea and may also alter the curvature. A patient are best fitted after pregnancy and when curvature has stabilized. That's why it's better not to fit during pregnancy or during uh, level of hormonal fluctuation. It's better always after pregnancy when curvature is stabilized, when cornea swelling went back to normal. Yes, current wear need to stop wearing their lenses and provide remote problem if fitting or other problems occur. Refitting or even cessation will need to be considered. So in case of pregnancy, sometimes you have to cease the contact lens of the mother. Yeah. So sinus problem, sinusitis is an inflammatory condition of the mucous membrane lining and the paracentral sinus. And patient with a sinus problem may be fitted with a contact lens and require frequent aftercare because patient may report discomfort and excessive tearing. That's always there. Yeah, that's why sinus problem patient you have to be cautious and put him or her in a frequent aftercare. So special conditions, ocular conditions. What are the special conditions? Existence of the ocular condition by may mean either patient should not be fitted at all or a special type of lenses may be fitted. It's very important. That's why ocular condition you must distinguish. Generally, a patient with the active eye disease should not fit it with a contact lens until the condition is resolved. It's always there. Yes, with the active disease, you generally or the therapeutic contact lens that's another story. But generally, if there is active eye disease, you must hold up. Generally, patient without ocular pathology but with either susceptibility or a history of eye disease are best fitted with a high decay. Definitely, we don't want oxygen deprived from the cornea deprived from the oxygen or disposable contact lens. So it's always better if there is history of some, like viral uh, keratitis. Then we must be cautious whether not to fit or fit with a high decay. Disposable contact lens. Wearing time may have be limited. It's another important point. So care regime should be tailored and the patient's condition and probably be preservative free. This is very important point. So if the patient's condition or if the ocular surface condition is weak, then we must think about preservative free because sometimes preservatives causes more allergy and more and more complications. Yes, frequent aftercare visit is advisable. It's always better to have frequent aftercare visible uh, frequent aftercare visit, and the distance between aftercare visit time frame should be shorter. Yes, yeah. So special condition medications, patient may be one or more medications in their consultation. So it's always better. You must know as an optometrist which medications they are using because a lot of medications create directly or indirectly like problem in tear film and ocular surface. That's why you have to understand which type of medications and side effect of the medications. Yes, and you have to mention these medications in your history, which is another important part, especially those medications which we patient put directly on the eye, like teardrop, like gels. Special consideration contact lens history. Patient may be current, previous, or failed contact lens wearer. I have already told you it like literally 40 times. Refitting successful is dependent on understanding an original problem and causes of failure because it's very important. If patient failed once in history, then you must know why he failed with the contact lens. So outlining the differential advantage of new and fitting is essential and informing patient that benefit of the deliver and expectation they should have. It's important. So other special consideration is their occupation, if especially assessment of each prospective contact lens wearer activities provide practitioners a better understanding. Suppose, for example, if someone is very sporty person, they want contact lens for sports. So we don't prescribe corneal lenses. We prescribe whether soft contact lens or scleral contact lens. Yes, because suppose, for example, someone wants contact lens as he's a swimmer. So at that particular point, you don't suggest him RGB contact lens, or you don't suggest him contact lens at all sometimes. But if you suggest contact lens, then you suggest definitely that swimming goggles. Yeah, there are a lot of things that has to be considered. So patient requiring some form of reading correction may be fitted with bifocal contact lens or alternative form of presbyopic corrections. So environmental factor we should take into consideration, we should take into account the exposure of environmental factor may determine the type of contact lens to be fitted. A patient who is exposed to dust routinely may be experience serious discomfort, isn't it? Especially with RGB corneal lens. So patients who work with the chemicals may experience staining irritations and when wearing soft contact lenses always there because chemicals soft contact lens can shock the chemical higher as compared to RGB contact lens because the permeability of the chemical vapors fume and the soft contact lens has porous contact lens. Yes, and that's another important point. So final evaluation. The final evaluation is the last phase of the preliminary examination prior to trial lens fitting. During this phase means you have collected all the information and all the data. The decision to proceed trial lens, specific type of contact lens is made based on the absence of majority of contraindication. That we have to understand is if there is majority of major contraindication or not. If there is no major contraindication, then we move. By this is the following information: there is no abnormality of the entire segment and predisposes patient complications to contact lens. All parameters essential trial is recorded, and tear volume stability is satisfactory. Corneal plane refraction, so this is the corneal lenses are available. So the power required is this all things we have, then we move into the trial phase. Yes. So the final evaluation, patient consultation, we'll do consultation. So basically means the specific need is vary. What are the need of the patient according to their visual demand, convenient and flexibility, individual ocular characteristics. These all things are important. Just pause this video and read these things. Okay. I think that's it. These are the three books, and great three books. Yes, I have taken a lot of from the history from this book, and these two books are also fantastic book. I think that's it from the from the side of preliminary eye examinations before contact lens fitting. I think this time choose.